Starting with case history. So 22 years old patient comes to emergency department with complaints of vomiting, severe dehydration and rapid breathing. So blood glucose levels were 480 milligram per deciliter. Urine ketones were positive. So this is a patient of, as you know, blood glucose is raised, so 480, ketone bodies are positive, patient is severely dehydrated. So answer is, patient is of diabetic ketoacidosis. So today I am going to teach you diabetic ketoacidosis management in simplest way possible. So by the end of this video, you all never forget three things: fluids, potassium and insulin. If you remember these three, you have mastered diabetic ketoacidosis management. So starting with diabetic ketoacidosis. So diabetic ketoacidosis is usually seen in insulin dependent diabetic patients. Diabetes type 1, right? But in 27 to 37% cases, there is no previous history of diabetes mellitus. So most common precipitating factor in diabetic ketoacidosis are inappropriate insulin dosing and concurrent illness, for example infection. So mortality rate of diabetic ketoacidosis patient is around 1 to 5%. So next is definition of diabetic ketoacidosis proposed by American Diabetic Association. It's a ADA criteria for diabetic ketoacidosis. So according to it, blood glucose should be more than 250 milligram per deciliter. Next is plasma bicarbonate. It should be less than 18 milliequivalent per liter. Then next is plasma pH. It should be less than 7.30. So next is elevated anion gap. It should be more than 10 to 12. Next is evidence of ketones in blood or urine, right? So these are the ADA criteria for labeling the patient as diabetic ketoacidosis. So next are manifestations of DKA. So how the patient present. First we'll start with the symptoms. So first symptom, patient will present with nausea and vomiting. So it is often prominent and their presence in diabetes warrant lab investigation for diabetic ketoacidosis. So second is thirst and polyuria. So hyperglycemia leads to glycosuria and volume depletion, which leads to thirst. Next is abdominal pain. So it may be severe and can resemble acute pancreatitis. Next symptom is shortness of breath. So now we'll start with the physical findings. So in physical findings, first is patient will present with tachycardia. Second, hypotension. Hypotension can occur because of volume depletion in combination with peripheral vasodilatation. Third is important one for MCQ also, Kussmaul's respiration. And fruity odor on patient breath. These are the classical signs of diabetic ketoacidosis. Next is abdominal tenderness. So it may resemble acute pancreatitis or surgical abdomen. Next is lethargy and CNS depression. may evolve into coma with severe diabetic ketoacidosis and should also prompt evaluation for other reasons, for altered mental status, for example, infections, hypoxemia, cerebral edema. So cerebral edema is extremely serious complication of diabetic ketoacidosis. So now we'll start with precipitating factors. So what are the precipitating factors? So you have to remember 4 I's. 4 I's. First is inadequate insulin administration. Second is infection. Infection can be in the form of pneumonia, it can be UTI, it can be gastroenteritis or sepsis. Third is infarction. So infarction can be of cerebral, coronary or mesenteric or peripheral. Next is intoxication. Intoxication like of cocaine, right? Next we'll start with pathophysiology. So what is the pathophysiology for diabetic ketoacidosis? So diabetic ketoacidosis results from relative or absolute insulin deficiency combined with hormone excess. Which are the hormones? Like glucagon, catecholamines, cortisol and growth hormone. So second point in case of pathophysiology, when ratio of insulin to glucagon is decreased, it promotes gluconeogenesis, glycogenolysis and ketone body formation, right? So if insulin is decreased, glucose is not entering into the cells, so body is in hypoglycemic state. So now the action of glucagon occurs. It raises the glucose by gluconeogenesis, by breaking down the glycogen and by forming ketone bodies from the free fatty acids. Next is markers of inflammation. Like cytokines, they are elevated. They are elevated in diabetic ketoacidosis. So next we'll start with the laboratory investigations, right? So in lab investigations, so as we know, in diabetic ketoacidosis, what are the 3 things? First is hyperglycemia, second is ketosis, and third is metabolic acidosis. So we will first investigate for glucose. Next is we will send ABG for metabolic acidosis, ruling out the metabolic acidosis. Then we'll send for electrolytes to see the potassium. Next, we will investigate for blood urea nitrogen. So it is elevated in case of DKA. Then we'll also do renal function test like creatinine levels. So it tells or reflects intravascular volume depletion. So another investigations, routine investigations like CBC for leukocytosis. Then we'll do lipid profile for hypertriglyceridemia. Then we will go for urine culture or blood culture for any source of infection, like we know the precipitating factors like UTI or pneumonia, right? So other investigations are ECG and troponin to rule out the triggering factor like myocardial infarction, right? Then next is amylase level. Amylase level. So there are raised amylase level in case of diabetic ketoacidosis, but it is mainly of salivary origin. So thus it is not a diagnostic of pancreatitis. So for diagnosing pancreatitis, you have to do serum lipase levels, right? So next investigation which you can do is osmolarity. So how to find osmolarity? It is 2 sodium plus glucose divided by 18 plus BUN divided by 2.8. So this osmolarity can differentiate between hyperosmolar coma, which is found in type 2 diabetes mellitus, and it is raised in diabetes mellitus 2. It is more than 320 in case of diabetes mellitus 2. So next we'll go for management part. So next is the management. So management is most important in case of diabetic ketoacidosis, because diabetic ketoacidosis is a medical emergency. So you have to remember 3 things. First is the fluid. That is the foremost important thing you have to give as you diagnose diabetic ketoacidosis. Second is insulin, and third is potassium, right? So these 3 things are most important in case of diabetic ketoacidosis. If you manage these 3 things correctly, you can manage diabetic ketoacidosis. So first, you will confirm the diagnosis with the EDA criteria. Glucose should be raised, there should be ketone bodies, there should be metabolic acidosis. So first point is you have to admit patient in intensive care unit, because it is important to monitor pH, right? So next is you have to send the investigations, as we have already discussed. Next is first point, that is replace fluids, right? So in diabetic ketoacidosis, there is volume deficit of around 4 to 6 liters for an 80 kg adult. So what you have to do? You have to start with 0.9% NS at 1 liter per hour. So if you want to calculate, it is 15 to 20 ml per kg per hour. I have to rewrite again. So it is 15 to 20 ml per kg per hour, right? So one bottle of 9%, 0.9% NS is 500 ml, right? So that means you have to give 2 bottles of normal saline in 1 liter, right? So which cannula, you should ask, which cannula we are using in case of patient. So we are mostly using pink cannula. So we have to flush the normal saline. Why flush? Because there is hypotension in case of these patients due to dehydration. So first we have to normalize the BP. So when BP is normalized, when BP normalizes, decrease the rate of infusion to 250 to 500 ml per hour. So first you were giving 2 bottles of 500 ml in 1 hour, right? So 1 bottle in half an hour, then again 1 bottle in half an hour, right? So now if BP is normalized, you have to decrease the rate to 250 to 500 ml per hour. So next point is, if blood glucose falls to 2 250 milligram per deciliter. So what you have to do, you have to add 5% dextrose in 0.45% of saline, and 0.45% is N/2, and decrease the infusion rate to 150 to 250 ml per hour. So infusion rate is further decreased. So starting when you are giving 2 liters of the fluid, 2 bottles of the fluid, what you are doing? You are increasing the perfusion, right? So if you have to look for sodium, if sodium is more than the normal value, that is more than 135, so you have to replace 0.9% NS with 0.045% NS, that is N/2, and if it is normal, you can continue with 0.9% NaCl, right? So this is the fluid part. Next is, you have to look for potassium first. You have to look for potassium. Why potassium? Because insulin causes potassium movement from extracellular to intracellular blood. So potassium decreases. So if serum potassium is less than 3.3 milliequivalent per liter, you have to hold the insulin infusion. So you have to remember, you have to hold the insulin infusion, right? So if you are holding the insulin infusion, you have to correct the potassium. So you have to give potassium KCl 20 to 30 milliequivalent of potassium per hour. So what this means is, you have to give 20 to 30 milliequivalent of potassium in 1 hour. That is the time, right? So one ampule of KCl comes in two forms. One comes in 15%, one comes in 7.45%. So for one ampule which comes in 15% dose is 20 milliequivalent of potassium. So that you have to add in the normal saline or N/2 saline, depending upon the sodium concentration, right? So you have to give 20 to 30 milliequivalent of potassium per hour till potassium is more than 3.3 milliequivalent per liter. Next, second, this was the first point. Second point is, if potassium is 3.3 to 5.2 milliequivalent per liter. So if it is value is 3.3 to 5.2, so in this case you have to give 20 to 30 milliequivalent of potassium per liter. So in this case, so you have to give 20 to 31 ampule of 15% KCl in 1 liter of IV fluid to keep the serum potassium, at 4 to 5 milliequivalent per liter, right? So in this case, you can use 1 ampule of KCl, which is 7.45%, that is equivalent to 10 milliequivalent in 500 ml of NS. Then you can repeat in another bottle, same 10% milliequivalent of KCl in another bottle. So third point is, if initially potassium is more than 5 milliequivalent per liter, so remember, in this case you don't have to give potassium. So remember, if potassium is more than 5 milliequivalent per liter, you don't give potassium, but you have to check potassium every 2 hours. While giving potassium, what you have to ensure? You have to ensure urine output. And it should be more than 0.5 milliliter per kg per hour. That means if patient is of 60 kg, suppose you should look for 30 ml of urine output per hour, right? Next is the insulin part. So insulin you have to give after checking the potassium. right? This point you should remember. So you should check potassium before giving the insulin, right? So in this insulin, one is the bolus dose and one is the continuous dose, right? So in bolus dose, you have to give 0.1 unit per kg per hour IV, right? What it means, if patient is of 50 kg, you have to give 5 units. If patient is of 60 kgs, you have to give 6 units, right? So next is the continuous infusion. So continuous is also same, 0.1 unit per kg per hour. Same. If 60 kg patient, 6 units. If 50, 5 units. 80, 8 units. Right? So bolus means you have to give IV on the spot. Then in continuous, you have to give in the infusion pump. Right? So and you have to give in the infusion pump. So in continuous infusion, you have to discard the initial 50 ml of the infusate because it is absorbed to the intravenous tubing, right? So you have to discard the first 50 ml of the infusate. So when blood glucose reaches 250 milligram per deciliter, blood glucose reaches 250, decrease the infusion rate to 0.05 units per kg per hour to maintain the blood glucose at 150 to 200 milligram per deciliter, right? Then you will begin the subcutaneous insulin when you have to begin subcutaneous when DK diabetic ketoacidosis is resolved. That is pH is 7.3 and patient is taking the oral fluids, but continue the IV infusion for few hours after starting the subcutaneous infusion, right? Next is, when is DKA resolved? So when is DKA resolved? When glucose is less than 200 milligram per deciliter, bicarbonates are more than 18 milliequivalent per liter, plasma pH is more than 7.3, anion gap is less than 12, and patient can tolerate oral fluids, then only you have to start the subcutaneous insulin. Next are the complications of diabetic ketoacidosis. So in complication, first is hypoglycemia, second is hypokalemia, third is cerebral edema. Why cerebral edema? Because firstly the glucose is very high, so after it leads to shift of the fluid into the brain cells, so that leads to cerebral edema.
So next complication is ARDS. So when we have to give IV bicarbonates, so IV bicarbonates we have to give if pH is less than 6.9. And one more thing, pH will normalize via hyperventilation, but you have to look for anion gap which reflects true ketone bodies, and AG closure is equal to metabolic recovery. So you have to look for AG normalization, right? So let's solve our MCQs. So first MCQ is, which of the following is not diagnostic criteria for diabetic ketoacidosis? First option, serum glucose more than 250. It's a criteria. Second option, serum bicarbonate less than 18 milligram per deciliter. Obviously, it's a criteria. Third, anion gap more than 12. It's a diagnostic criteria. So fourth MCQ, serum osmolality is not the diagnostic criteria for diabetic ketoacidosis. So moving forward to next MCQ, in patient with diabetic ketoacidosis and serum potassium of 2.9 milliequivalent per liter, next best step is, so first option is start insulin infusion. No, second is give 1 mg bicarbonates. So bicarbonates are only given if pH is less than 6.9. Third is potassium replacement. So answer is third. Why? Because we have learned potassium if less than 3.3, we have to give the potassium first, right? So this is the answer for this MCQ. So at the end, I will say DKA is not just an exam question, it's a life-threatening emergency that every healthcare professional should recognize and manage confidently. I hope you understood diabetic ketoacidosis. Thank you so much.